Good afternoon and welcome to the HL7 Da Vinci Community Roundtable. Today's session is No Surprises Now, how the HL7 Da Vinci project accelerates patient cost transparency. My name is Alex Goss, and it is my pleasure to moderate today's Community Roundtable and to remind all of us that we engage in these forums under HL7's antitrust policies to ensure appropriate collaboration and information sharing. We are grateful for your participation in September's Community Roundtable, Da Vinci's monthly educational webinar. Today's agenda starts with offering key program updates, as our primary focus for today's webinar is patient cost transparency, or PCT, as we refer to it in shorthand. We have a terrific lineup of PCT experts joining me today. They'll first deliver an initial level setting on the regulatory landscape, including the No Surprises Act and related regulations and resources. Then we'll learn about the Da Vinci PCT use case to round out the foundational context before diving into a panel discussion. I'm super excited for our multi-stakeholder panel featuring representatives across our ecosystem that include a payer, provider, vendor, standards development, subject matter expert, and regulators. Today's presenters include Vanessa Candelora, Senior Consultant, Point of Care Partners, Tina Mintyala, Program Manager and Revenue Cycle at Providence, Alice O'Carroll, Interoperability Product Manager from Florida Blue, Carmen Smiley, Health Insurance Specialist, Division of Consumer Protection Policy, Consumer Support Group at the Center for Consumer and Information and Insurance Oversight at the Center for Medicare and Medicaid Services, Zachary Welch, Executive Director, Pre-Services at Providence Health and Services, and finally, Jacob Woodford, Technical Services at Epic. Beyond the diverse stakeholder representation today, it's great to have the HL7 Da Vinci Project Patient Cost Transparency Leadership Team with us. We've included time to take audience questions at several points throughout the webinar, so please use the question function in today's GoToWebinar panel to submit your questions. A bit of housekeeping. We'll post the recording of today's webinar and slides on Da Vinci's video presentation page on Confluence. Da Vinci's communication lead, Leslie Ambrose, will be posting links in the chat box to assist in locating that page and other resources you may find of interest. We have muted your lines to aid in the recording quality. Should you encounter audio issues, we suggest rejoining the webinar or obtaining audio by dialing in using the number provided in your registration. Finally, we appreciate your survey feedback solicited at the end of the webinar. The next Community Roundtable is scheduled for October 25th, 2023, the fourth Wednesday of October. There are 4 events I'd like to highlight for you today. NCQA's Health Innovation Summit, October 23rd through 25th, and you can get the link for any of these events in the slides, which we'll post tomorrow. November 6th to the 9th is the WEDI National Conference in Washington, D.C. November 15th, CMS is holding their 2023 conference on optimizing healthcare delivery to improve patient lives. That's an all virtual event. And December 14th and 15th, ONC returns to in-person annual meeting in Washington, D.C., which we hope to see many of you there. Let me now pivot from some housekeeping into key program updates. This slide represents the Da Vinci Implementation Guide roadmap. For context, it is an overview of our discrete implementation guide work and related ballot cycles and can assist you in resource planning, whether financial or human, to ensure your organization and teammates have the knowledge, tools, and context to advance interoperable and efficient information exchange as a part of advancing your organization's mission. We produce a roadmap on a yearly basis, and then we update it as we go throughout the year. So I wanted to highlight a few key revisions since our last webinar. The changes that were just made to the roadmap relate to the December and January activities, in that we revised the potential standard for trial use, or STU, updates and related ballot cycles for the end of this year and for Q1 of next year. Doesn't really affect anything in the pipeline right now, just really reflects the reality that we're facing with workloads and estimated plans. I highly encourage you to join future community roundtables, as we'll deliver a deep dive update across all of our use cases at the October webinar. In November, we'll wrap up the 2023 series of community roundtables with showcasing overall project progress and introduce our plans for the 2024 scope of Da Vinci project work. As for other use case updates, I'd like to highlight a few key updates. I want to make sure that you're all aware that the burden reduction implementation guides, coverage requirements discovery, documentation templates and rules, and prior authorization support are all in their final stages of publication, which includes completing the applicable HL7 work group process points so that we can complete the balloting and publication processes. For the clinical data exchange use case, which is a one we've talked about occasionally here on the roundtable, it's going to be going through some PI workgroups changes. What I mean by that is that the PI workgroup is now going to be the primary sponsor for that use case. Da Vinci is advancing the use case, but does all of our work with the corresponding workgroup sponsorship at HL7. Another update is related to the value-based performance reporting, or VPPR, as we call it for shorthand. They have started work on their ballot reconciliation. We encourage all of you to become engaged, and so you can identify a few key opportunities. You can participate in the PCT weekly calls, Wednesdays at noon, and learn more about that in just a little bit from our presenters. Risk adjustment standard for trial use ballot reconciliation is taking place on Thursdays at 3 p.m. with PlanNet ticket review taking place on the second Fridays of each month at 1 p.m., which is a part of the larger PDEX provider payer data exchange public calls. Also in the PDEX public calls, we're addressing formulary ticket reviews on the third Friday of each month at 1 o'clock. And the ballot reconciliation for value-based performance reporting, STU1, is taking place on Mondays at 2 o'clock. The full use case schedule is provided at the link here, and there's also appendix information that provides additional overview of core Da Vinci resources, and those will also be available with the slides that I will post early tomorrow. All right, so at this point, if you have any questions, please drop those in the comment box. Jocelyn Keegan will be assisting us today with monitoring the question box and supporting us when we get to our final Q&A after we get through our level setting. So at this point, what I'd love to do is introduce our first presenter, Carmen Smiley, to come on screen and kick off our patient cost transparency, or PCT, content. Thanks. And I'm going to be advancing your slides, so feel free to just let me know when you'd like me to go to the next one.
Excellent. Thank you so much, Alex. Hopefully everybody can hear me. As Alex mentioned, my name is Carmen Smiley. I am here representing the Center for Consumer Information and Insurance Oversight at CMS. And I'm really looking forward to the discussion on patient cost transparency. We'll be providing a statutory and regulatory landscape. Next slide, please. Thank you. Before we jump into the agenda, I just wanted to say a few words about transparency. As regulators, we are looking at price transparency holistically and how the different price transparency provisions, so that would include the summary benefits and coverage, the transparency and coverage price comparison tool and machine readable file, the hospital transparency requirements, and the GFE and AEOB. Increase my voice?
Yes, and I messed up. For some reason, someone says they're not seeing the slides. So I wanted to make sure, for some reason, it paused my screen.
Nope, you're good, Alex. You're advancing.
We
So
can see them.
if you're having problems online, just leave the webinar and return. Sometimes people get frozen. So
Thanks. Sorry for the interruption. Just didn't want people to miss your content. I'm going to go back off screen and off mute and go ahead and continue.
Okay, great. So thank you. So as I was just mentioning, so we are looking at price transparency holistically. I mentioned a number of provisions that we're currently exploring. And I think I was at the hospital transparency requirements and the GFE and AEOB. So we want to ensure that all of these different price transparency provisions are working together as a suite of tools. So each of these tools is intended to serve a specific purpose within our larger goals of helping individuals understand their expected healthcare costs, empower them to make cost-conscious decisions about their care, and ultimately to increase competition and help to contain healthcare spending. But we also want to ensure that these various provisions complement each other and are in alignment and have sought stakeholder input on how best to do that. So for example, in July of this year, CMS published a proposed rule that included RFI questions on whether and how hospital price transparency requirements might be revised to better align with our other transparency initiatives. So including the transparency and coverage requirements on plans and issuers and the GFE and the AEOB. The comment period closed earlier this month. Thank you to all of those who sent in comments. We're currently in the process of reviewing this comment. But today I will primarily be focused on sort of an overview of GFE and AEOB. We'll talk about the applicability. Thank you so much, coming back to the agenda. The applicability of GFE and AEOB requirements, and forgive my overuse of acronyms. I'm a federal employee. So GFE will always be short for good faith estimate, and AEOB advanced estimation of benefits. We'll talk about applicability, provide a quick overview for insured or self-pay individuals, also for covered individuals, and I'll provide an overview of advanced explanation of benefits requirements as well. I'll provide a quick overview of transparency and coverage, and a very quick touch on hospital price transparency. Next slide, please. So for the applicability of GFE and AEOB requirements, specific to uninsured and self-pay individuals, these requirements are applicable for any GFEs requested on or after January 1st, 2022, or for GFEs required to be provided in connection with items or services scheduled on or after January 1st, 2022. HHS issued interim final rules implementing GFE requirements for uninsured or self-pay individuals on October 7th, 2021. For covered individuals, HHS is deferring enforcement of the requirements for GFEs for covered individuals currently. And regarding advanced explanation of benefits, the Departments of Labor, Health and Human Services, the Treasury, and OPM are also deferring enforcement of the requirements that plans and issuers must provide these covered individuals with an AEOB. Next slide, please. A quick overview of GFE requirements. So Section 112 of the No Surprises Act requires providers and facilities upon an individual's scheduling of items or services, or upon their request, to inquire if that individual is enrolled in a health plan or health insurance coverage, and then provide a notification of the good faith estimate of the expected charges for furnishing the scheduled item or service, and any items or services reasonably expected to be provided in conjunction with those items and services. So including those provided by another provider or facility, with the expected billing and diagnostic codes for those items and services. On October 7th, 2021, HHS published interim final rules that also included good faith estimates for uninsured or self-pay individuals. Next slide, please. A continuation of an overview of GFE requirements. So if the individual is enrolled in a health plan or coverage and is seeking to have a claim for the item or service submitted to the plan or coverage, the provider must provide this notification to the individual's plan or coverage. In the case that the individual is not enrolled in a health plan or coverage or does not seek to submit a claim for the item or service in question to their plan or coverage, the provider must provide this notification to the individual themselves. Next slide, please. GFEs for uninsured or self-pay, just a little bit more information here. So the GFE is essentially a notification that outlines an uninsured or self-pay individual's expected charges for a scheduled or requested item or service. Providers and facilities must give this estimate to the uninsured or self-pay individual or their authorized representative who requests it or who schedules an item or service. So the GFE also includes items or services reasonably expected to be provided in conjunction with the items or services, even if those are from another provider or another facility. These requirements are applicable to GFEs requested on or after January 1st, 2022, as I mentioned before, or for GFEs required to be provided in connection with items or services scheduled after January 1st, 2022. Next slide, please. Extended enforcement, the HHS has extended enforcement discretion for situations where GFEs for uninsured or self-pay individuals do not include expected charges from co-providers or co-facilities. And we provided a link to FAQs here on this slide, but at the end of the slide deck, there's also links to a number of other resources that we encourage all of you to review. I know that Da Vinci is excellent about providing copies of slides after the webinars, after roundtable webinars. Next slide, please. GFEs for uninsured or self-pay, also regarding the scope of care. So the scope of care that is expected to be included in good faith estimates. So under the NSA, individuals should receive a single comprehensive GFE that includes expected charges for the primary item or service that will be furnished by the convening provider or convening facility, and that is the initial reason for the visit. But all items and services that are reasonably expected to be provided in conjunction with the primary item or service should also be provided during a defined period of care. And these items or services can include any of the following: so any encounters or procedures, medical tests, supplies, prescription drugs, durable medical equipment, or any associated fees. Next slide, please. And the time frames, which is especially important to providers. So convening providers and facilities must provide a good faith estimate to uninsured or self-pay individuals within the following time frames. So when a primary item or service is scheduled at least 3 business days before the date the item or service is scheduled to be furnished, the GFE must be provided no later than 1 business day after the date of scheduling. When the primary item or service is scheduled at least 10 days before such item or service is scheduled to be furnished, the good faith estimate must be provided no later than 3 business days after the date of scheduling. When a good faith estimate is requested by an uninsured or self-pay individual, the good faith estimate must be provided to that individual no later than 3 business days after the date of the request. Next slide, please. A quick overview of the advanced explanation of benefits requirements. So Section 111 of Title I, Division BB of the CAA requires group health plans and health insurance issuers offering group or individual health coverage in response to either a notification from a provider or facility or request from a patient, beneficiary, or enrollee or covered individual to provide an AEOB to that covered individual. So the AEOB must include the GFE of expected charges received by the plan or issuer from the provider or facility, as well as benefit information based on the GFE, such as the estimated portion of costs for which the covered individual will be responsible. Next slide, please. Okay. Quickly regarding transparency and coverage, so as of 2022, the transparency and coverage rules require most group health plans and issuers in the group or individual market to disclose pricing information in 2 ways. So one is the machine readable files containing the following sets of costs for items and services. That includes in-network rate files, so rates for all covered items and services between the plan or issuer and in-network providers, and allowed amount files, so allowed amounts for and billed charges from any out-of-network providers. Regarding the machine readable files, I also want to mention that the RX machine readable files, the enforcement for the RX machine readable files, enforcement is also currently deferred. Also want to mention the internet-based price comparison tool, also available in paper form upon request, depending on the individual, allowing an individual to receive an estimate of cost-sharing responsibility for a specific item or service from specific provider or providers. Next slide, please. So there are, it looks like the bottom of the slide might have got caught up, but it could be my view. I hope that's just my view. So there are 3 stages of implementation of the transparency and coverage provision. The first stage is the 3 separate machine readable files, or MRFs, one for each in-network provider, rates, out-of-network allowed amounts and billed charges, and negotiated rates and historical net prices for prescription drugs. Stage 2 includes internet-based price comparison tool or disclosure on paper upon request, allowing an individual to receive an estimate of their cost-sharing responsibility for a specific item or service from a specific provider or providers for at least 500 items and services identified by the department. Again, the departments are the departments that are involved with the Price Transparency or No Surprises Act provisions. So that would be the Department of Labor, Treasury, Department of Health and Human Services, and OPM. And stage 3, the internet-based price comparison tool or disclosure on paper upon request, allowing an individual to receive an estimate of their cost-sharing responsibility or a specific item or service from a specific provider or providers for all covered items and services. Next slide, please. Here's a sort of an overview of the implementation timeline for transparency and coverage. So if we start from the beginning, we're looking retroactively or retrospectively at the transparency and coverage final rule was finalized by the departments and they appeared in the Federal Register on November 12, 2020. There we have a notation here that technical guidance was issued on GitHub, but I just want to direct viewers to the footnote here where the GitHub repository will remain active and continue to incorporate new developments after 2022 and encourage you to also check those out. And then we jump to stage 1, which is where the departments begin enforcement of the in-network rate file and the out-of-network allowed amount file requirements. Again, in stage 2, internet-based price comparison tool for 500 items and services requirement took effect at the very beginning of this year. And in January 1st, 2024, which is just around the corner, the requirements are that there be an internet-based price comparison tool for all items and services. Next slide, please. A little more about the machine readable files. So as I mentioned, as of July 1st, 2022, the departments have begun enforcement of the requirements for non-grandfathered health plans and health insurance issuers offering non-grandfathered coverage in the group and individual markets to make the following 2 machine readable files available on an internet website without barriers to access. So there is the in-network machine readable files, rates for all covered items and services furnished by in-network providers. And then there's the out-of-network allowed amounts machine readable files, including allowed amounts and billed charges with respect to covered items and services furnished by out-of-network providers. Next slide, please. And I've also mentioned the internet-based price comparison tool requirements at stage 2 and 3. The internet-based price comparison tool must permit members to search cost-sharing information for specific healthcare items and services based on billing code or description. Allow members to compare costs across both in-network and out-of-network providers. Inform members of the individual status related to plan or policy accumulators to date, so things like deductibles, out-of-pocket maximums, visit limits, things like that. Allow members to search by factors that impact cost, so such as service location, facility name, or drug dosage. And as an alternative, plans and issuers must provide cost estimates in paper format, again, at the individual's request. Next slide, please. And quickly touching on the hospital price transparency. So as of January 1st, 2021, each hospital operating in the United States is required to provide clear, accessible pricing information online about the items and services they provide in 2 ways. So as a comprehensive machine-readable file with all items and services, and in a display of shoppable services in consumer-friendly format. This information makes it easier for consumers to shop and compare prices across hospitals and estimate the cost of care before going into the hospital. Next slide, please. As I mentioned, there's a number of resources at the end of the slide deck. We encourage all of you to check them out. But overall, we also encourage you to read through the many resources that CMS has developed over the years and has available on our website, including frequently asked questions, just that it is very likely that many of your burning questions are already on there and you can get a very quick answer. The teams worked very hard to make this clear and accessible to everybody. I really appreciate the opportunity to speak with all of you today, and I'm really interested to hearing more from panelists on their thoughts and any sort of issues that they would like to explore. Thank you.
Well, thank you, Carmen. That was a fantastic overview to level set us on the regulatory landscape. I believe at this point, we're now going to have Vanessa Candelora start sharing her screen and to advance us into the next slides, which will help us with understanding the technical specifications that have been developed to support this community's GFE and AEOB objectives. Vanessa?
Thank you so much, Alex. Am I coming in okay? And can you see my screen?
Yes, and yes. Take it away.
Perfect. Thank you so much. And that was an excellent presentation, Carmen. Thank you so much. Looking forward to talking with all of you a little bit about the Da Vinci patient cost transparency use case that we have been working on for quite some time. And then we'll, as Alex described at the beginning, the panelists and I will all answer questions, which we're really excited about. So, okay, this slide, if you have ever been to a Da Vinci Community Roundtable in the past, you have seen a slide similar to this across all of our use cases. This gives you a summary of the use case, kind of in one slide nutshell. I want to point out that the dial is pointing all the way over to the right, indicating that we have a completed published STU1 guide, Standard for Trial Use Guide. And that guide is in support of the Consolidated Appropriations Act, No Surprises Act, that includes the good faith estimate exchange from providers to payers and the advanced explanation of benefit to patients. And you'll hear me say that a lot of times, but I'm very pleased to share that with all of you. The recent updates, so we published it in March 2023, and those bullets there in the bottom left corner talk about some of the key updates from the balloted version, which was back in January 2022. We received over 240 comments on our guide. We went through almost all of them individually with the community, building consensus through discussion and conversation, which carried not just into the GFE and AEOB for No Surprises, but as Carmen was talking about, transparency holistically in this country. And so a lot of really great discussions happened on our weekly calls. We have since started phase 2, which I'll talk a little more about in February of this year, focused on a good faith estimate for multiple providers being involved in a period of care. We encourage you to get involved with us, come test with us. That will be a theme throughout the next 20 minutes or so while I'm talking. Adopt the guide. We want to learn from you. We want to test it out, fix what needs to be updated. And we encourage you all to get involved and contribute, engage with us, help us shape this standard in a way that makes sense for the industry and for patients. So we do expect regulation to support the legislative activity that is happening and has already happened in Congress, and continues to be a very vibrant community talking about transparency of costs and prices in healthcare. And so the links are all here for you. And I'll move on to a little bit of our history. So I saw in one of Carmen's slides that in the fall of 2020 was when that transparency in coverage rule came into play. And Alice O'Carroll and I remember very vividly, we were having a patient cost transparency session in the morning. I think we had a big sort of 4-hour powwow about it when that actually occurred. So we've had a lot of great discovery since then. We, fast forward to the No Surprises Act really taking legs and us evaluating that and getting aligned to that scope. Very simultaneously, we supported a work with our X12 and a crosswalk between X12 and FHIR. We opened up our community weekly calls to do requirements gathering and gap analysis to FHIR. Lots of testing and connect-a-thon opportunities, lots of design, as I mentioned, balloting and ballot reconciliation, and finally to our published guide in March of this year. As I mentioned, we have moved on to phase 2 requirements, and we look forward to testing in January in the virtual HL7 Connect-a-thon event also. This is our project team, so you'll recognize some of these names from the introduction, as well as we're very grateful for our in-kind resources from Lantana. Aegis is our testing, and we have a number of other subject matter experts that join us. Thank you all to all of you and to our community. So this is a use case summary for the standard for trial use 1 that was published. At our highest level for this entire use case, we are developing a standard data exchange in support of patient cost transparency, devices, services, collection of services or period of care, using FHIR APIs for exchange of data. In our STU1, we developed the ability to communicate good faith estimates for a single service or collection of services and items from a provider to payer, to communicate an advanced explanation of benefits from a payer to a patient, and also optionally to a provider, which is what that dotted line over here is. I'm not sure if you can see my mouse, but that is between the payer to the provider, because our community felt strongly that having the providers involved in all of the information to have parity and equity of information would really help move the needle forward to help make informed decisions using cost for care by patients as one of the many factors that go into the decision making for a patient. And we very clearly had an objective to support current and future regulations to enable compliance in a way to support the industry for that compliance factor. This is a similar view to what you just saw, slightly more technical for those FHIR folks out there. So the process really kicks off. The trigger is the GFE submit to the payer, which is a post request right here, number 2. And then the AEOB is a get request to the payer. And then there's that optional AEOB response back to the provider as well. And so the support for the return to the provider is not outlined in the law, but we agreed it was critical for health equity, as I mentioned. There is a no HIPAA mandated transaction for patient cost transparency. So there's other transactions that HIPAA mandates, but PCT is not one of them. And as Carmen pointed out, we live in acronym world, so hopefully GFE and AEOB will be ingrained in your mind if it's not already by the end of this presentation. This is our implementation guide, and so as I mentioned, it is published as a standard for trial use, ready for adoption. It is an interoperable guide. FHIR APIs are defined. The idea is that we are enabling organizations to have an easier implementation for this pretty new workflow that isn't necessarily in a lot of operations today, and set you up for success for that coming regulation. We know that this is coming. We have an opportunity to do it in FHIR in a standard way to try to reduce or eliminate any burden that could occur should people get sort of behind on figuring out how to do this. And so that's the opportunity that the Da Vinci community has leaned into, and we encourage you to take advantage of that collective mind for easier implementation and interoperability. We've had some real-world implementation activity, which our panelists will talk a little bit more about as well, where they are in their journey, but there's opportunity now to implement. There was some demonstrations of pre-production good faith estimates through payer claims adjudication systems to produce an AEOB back at HIMSS 22 in Orlando, and then almost 8 Connect-a-thons. This coming January will be the 8th Connect-a-thon. And so we've received some really positive feedback. We've heard that our implementation guide design is very effective and simple. It leverages other implementation guides that similar organizations may need to be implementing. So things like member match, you don't need to reinvent the wheel there. We're pulling together what is already in existence and pointing to it where appropriate. And it also aligns with other standards for easy mapping. And we've learned a lot in that process, and also sort of where the gaps are within the industry to be able to advance standards further to support the needs of patient transparency and cost. So now we move into our phase 2. So I just summarized the published implementation guide, GFEs to payers and AEOBs. And our phase 2 goal is actually upstream of that work. And it's where there are multiple providers involved in the patient's care and finding a way to coordinate the sharing of information to provide a cost in advance of a service when multiple providers are involved. So that's what this phase 2 box is. It looks really simple here. The request and response may involve additional actors, and I will show you that in just a moment. There's a lot of challenges to address. We did not scope this into our phase 1 of this guide purposefully. It can be complex, and we've had really great discussions. These 3 very high-level challenges are the summary level, but identifying and coordinating the providers, whether they're participating in the service, whether they're in network or out of network or needed, is something that we've talked a lot about. Also gathering the good faith estimate information and convening and co-providers or convening facility and co-facility is a lot of our discussions of how that works, what that means. We've done a lot of great work there. And also making sure that we're leveraging existing technologies and vendors that are already participating in this space, whether they be EHRs where the data is at rest, RCM processes, and lots of different opportunities to leverage existing technology where possible and not try to reinvent the wheel, recognizing that some of this isn't happening today and some of it is manual. So a little more in depth, I won't read through all of this, but again, our phase 2 goal is to support good faith estimate data exchange via FHIR APIs when multiple providers are involved. And we've also left room for any updates to our STU1, enhancements or changes, including adding an AEOB summary where there's multiple claims included or multiple explanation of benefits that may span different providers or within one provider. We wanted to have a holistic summary for patients, and that's work we actually just completed in this past week. And so it's in a draft form in a continuous integration build we're excited about. And also building out a linking identifier capability, which we'll talk a little bit more about, or you can join us on Wednesdays to talk further about. So we have room for fixes and improvements through learnings. For our phase 2 workflow, we put together a clinical example for a good faith estimate collection across providers for self-pay and uninsured as a first example. This is one example scenario. I won't read through it, but wanted you to all see that it involves a facility, a surgeon, and an anesthesiologist, and how that could play out as one example for convening and co-provider coordination. This is a visual view for those of you that are more picture focused. So what happens here is we've introduced a coordination platform that would be of the convening provider or facility's choice, and they would be sort of the aggregate for that information, where the good faith estimate information gets requested to all the co-providers and responded to be pulled together to finalize and generate a response to the patient. And as I mentioned a few minutes ago, our enhancement as part of phase 2 to our Standard for Trial Use 1 is an advanced explanation of benefits summary, where we wanted to put totals across the bundle. So this is a picture of an AEOB bundle, which is really just a container for the information for the different FHIR profile resources and resource profile, and includes totals that would be relevant for the patient should they be interested in using that information to make informed decisions, and can also always dig deeper into the individual AEOBs that are included, as well as the referenced good faith estimates, as Carmen pointed out earlier. So we hope that you will join us. We used to meet on Fridays, and we just recently switched over to Wednesdays at 12 noon Eastern time. So please join us, bring your subject matter experts. We are always looking for new voices. I have some listed here: office managers, health IT, revenue cycle, cost transparency colleagues, to continue to validate and help us iterate on our standard and the API approach between providers, which is what we're focused on right now, as well as enhancements to our existing guide. So check it out. We encourage you to take advantage of the opportunity to look at this guide now, contribute to this standard, test it, help us learn from it. We know that this regulation is coming to support the law that's gone through Congress, and so we urge folks to get ahead of that and not let it become burdensome if that should happen. So we have a standard, it's available and ready for you. Thank you. Any questions?
I think one of the things we want to note, Vanessa, is that in addition to the slides that you've provided, in the version we'll post tomorrow on the Da Vinci Confluence video presentation page, there are additional appendices that give a lot more additional information about the PCT use case. So I think it was really thoughtful of you to include that content. We would love it if folks would post their questions into the question box on the GoToWebinar panel. And while we do that, maybe you want to advance to the next slide for us. Because folks will also be able to get your email address from the slides if they want to send you PCT questions specifically. So if you go to the next slide, I'm going to invite all of our panelists to come on screen. We've already introduced them to you once, so I'm going to skip to the next step and have Vanessa show us the audience all of the instructions for submitting a question. So what I'd like to do next is also follow through with putting myself on screen and have us start to do our round robin. So it was great to actually have a chance to meet with everybody on the panel in advance. And so we teed up some of the questions that we thought would make a lot of sense to walk through, because the goal here is to help industry understand the different perspectives, the value proposition, the challenges, the stressors related to price cost transparency, or PCT. So what we're going to do here in this next segment of today's webinar is we're going to run the table. We're going to ask some questions and then supplement them with any questions that you may send in. So the first question that I would like to ask everyone is, why is your organization so interested in this use case that you're willing to lean into the development work? So any volunteers to go first? Alice, take it away.
So we found here at Florida Blue that getting really engaged with these different work groups has enabled both our business, our IT, and even really our compliance and legal and privacy folks to really understand where the industry is headed. It helps us to kind of get a sneak peek, if you will, at where things are going, and helps us to avoid getting too far down the line on an idea or concept that would work great for us, but then we might wind up in a position a year from now, 2 years from now, 3 years from now, where we have to throw that work away to then be compliant with what the regulators are requiring from us. So we found this, to be really beneficial, but also really important to have people from the business side and the IT side, and again, your legal compliance, privacy folks as well, because all of them have a huge say in where this goes and how we do things. And some of cost transparency is things that payers and providers have been doing for a long time because it made good business sense to a certain extent. And now we're having to say, okay, this is where we were, this is where we have to be, because we now have regulation around it. I see Carmen really nodding her head with a lot of this. So that's why we've done it. That's why we've gotten engaged. And that's where we're seeing value for our organization. The call earlier today, there was an internal, chat questions bouncing around amongst ourselves about some of the things that were being discussed as a part of the public call. So it really helps to bring people together internally as well.
That's a great duality of not only this from a business efficiency perspective, but also that knowledge sharing that happens in parallel for the standards development work with the internal development effort, and also harnessing your subject matter experts, because we can't all be in all places at one time. So having that larger network within your payer environment really helps to bring more subject matter expertise in. So I'm curious, now that we've heard a little bit of the payer point of view, who else would like to go?
This is Tina, and I'll chime in as well. I think it's advantageous to participate and talk about the patient's real world experience as they're coming into a healthcare platform. Talk about what we have to work with, what we don't often have to work with, and the gray areas that are in that space. I think that elicits some challenges, both as you come in from the provider side, but also on the way to the payer side. It helps us to understand how we can best create that harmony. The end goal, of course, being that we want to make sure that the patient doesn't have surprises, they understand what's coming their way. And then equally important, and I think Vanessa called this out, that kind of that copy of the AEOB back to the care team also puts us in a position to understand what the total experience the patient might be going through in the event that perhaps maybe they might need some financial assistance. So it's not really a stop and go in that price transparency space. It starts way before that happens and it ends way after that happens. And how can we create that collective full experience for those patients?
Thank you. It's good to add in the provider mix into the conversation. Zachary, from that perspective, do you want to chime in? I know that that's the hat you wear at this table as well.
Yeah, I mean, just to echo kind of what Tina and Vanessa have already mentioned, just from the patient perspective, that's the kind of the direction we're heading, and making sure that they understand from the very beginning to when they true it up at the payer side, and it becomes more accurate.
Maybe we can round it out with a regulator, a SME subject matter expert from the SDO, or the vendor Epic perspective. Who'd like to go next?
Yeah, I'm happy to jump in. From the Epic perspective and being a vendor that's been developing price transparency tools for over a decade now, we've definitely seen in the community a greater sense and drive to provide patients an upfront estimate and information to help navigate the complexities of what their care is going to cost them. We've had goals for a long time to provide an estimate for every single visit that is comprehensive and easy to understand. So engaging in the community has really helped us get broader perspectives and get to work with organizations that are using Epic as their EHR or practice management vendor, as well as groups and provider organizations that are using other systems to understand the complexities and challenges. As a group that has quite a bit of depth and experience here, we also get to share our experience with the rest of the community and help shape and design how we think this can actually be accomplishable across all of the parties.
Thank you. Others who might want to weigh in?
Just from the Providence perspective, we're doing about 60,000 estimates a month, and that's just for diagnostic imaging and surgical. So we really are fully invested in the process for our patients. We've already started to get a lot of really good feedback from our patients, and their main concern is really wanting to understand the bill up front, from the itemized charges to the allowed amount. So Providence definitely is forward thinking here and definitely has some experience in this space.
All right, excellent, thank you. All right, I'm gonna final call on why you're so interested in the use case before I move on to the next question set. Okay. All right, so if folks, just so you know, if folks want to get more of the attendees, panelists, compared to the question prompt at the bottom, you can actually slide your bar to minimize the slide and maximize the pictures. Otherwise, if it's in people's way, we can also have Vanessa stop sharing. All right, so the next question I would like to ask is, where are you in your development of solutions for transparency, and how has the Da Vinci implementation guide accelerated that development? So sort of tiptoed into this already a little bit, but maybe Jacob, do you want to pick us up there?
Sure, I'll kick us off. Like I mentioned, we've been developing price transparency tools that cover a lot of the use cases that Carmen had shared for regulations and beyond for a number of years. So where we're at right now with the Da Vinci use cases, we're still in the brainstorming design phase of how to incorporate our current and existing tools that have helped groups for a long time provide an estimate upfront to patients as they go through services. We are hoping that standards do help us speed that process along. Ultimately, we can't be everybody doing their own thing. So being part of this has really helped kind of shape that direction and advocate for a standard that's out there that will help speed us along in that process. But we're still very early in working through it. We've started to lay foundation of incorporating into our tools, though.
Others who are in development and want to answer this question for the benefit of the IG?
Well, I can say that, you know, Florida Blue with one of our vendor partners, EdFX, has you know, done some piloting proof of concept using the initial STU1 that we did, and we presented that at a couple of HIMSS and some others, and obviously at Connect-a-thons. It really is helpful as you are taking something that's new like this and being figured out and what works and what doesn't work. And again, it helps you to inform some of your internal decisions that you're making when you go through these processes and you know, say, hey, can we do that? Do we? And it's a way also for you to grow knowledge. I mean, when you think about FHIR, it's, you know, the Fast Healthcare Interoperability Resource format is new to the industry. Most organizations are having to train internal resources how to work with this new technology, if you will. And this is a great opportunity for those people, you know, in a safe environment to get some of that knowledge and stay cutting edge as well. So that's another benefit is of being engaged with some of the development of the solutions and stuff is for your internal resources to have an opportunity to play, because there's not, I mean, if we all tried to go hire everybody, there's not enough people out there who know how to do it.
Are you finding you have trading partners who are interested in supporting you in this effort? And because it's one thing to be able to think about it with your own team, but you really need somebody sitting across the aisle, so to speak, to create those exchanges. So, is there an interest in your colleagues, your trading partners in this effort as well? I'm curious.
So far, yes, we've definitely seen that. I've also in some of the other organizations that I'm involved in with providers like MGMA, really encouraged them to lean into their EMR vendors, and say, hey, can I be a part of your beta? Because, Jacob just said, we've been doing this for a long time. We've been trying to develop. EMRs don't always know exactly what your workflow is, because what Providence does or what somebody else does, not all provider offices are identical. Not all specialties are identical. There's a lot of nuances from the provider lens. So, Epic is not going to be able to create, and no other EMR is going to be able to create something that is amazing for everybody. It's not possible. Even EMRs that focus on a particular specialty often fall short on that, right? But this is an opportunity for the providers to lean in and help EMRs to do the best possible for the most possible. And they all win. We all win from that, because then that also helps the payer, because if the system is easy for submitting the information for the payer to then do their part and send back, if it's easy for the provider to do that, the EMR is enabling that to be an easy process, that helps everything. It reduces the burden for everybody, because right now that burden's pretty high.
Others who want to comment on this trading partner dynamic and the development status within your own organization?
I'm just going to add quickly to what Alice said, if that's okay, Alex, and then I'd love to hear from others. But I just think that that's so important, and I want to emphasize that, everyone has their own processes, their own operations, their own existing tools. This isn't like fresh slate, right? But it is not what a lot of people are doing today in the way that it's described, right? I think it's sort of taking it up a notch for patients to have that transparency. And so thinking about what impact that has on operations and how you work with your partners is just so important. And Alice, you said it so well. And I think that the more everyone can do it in a same or similar way, the better we're all going to get at it. And right now, there's a lot of different avenues for cost information, right? Carmen outlined where the regulatory space is headed, and there's already existing tools. Some of them are from providers or systems, some of them are from payers or portals, some of them are third parties that are getting involved in this space. And so, if you get if you're putting on your patient hat for a second and you get a different estimate from all these different places, what kind of experience is that going to be, right? So the leaders that we have here today that have been doing this for a long time, that have been honing that process, getting closer to accurate estimates, which we know is more challenging for some than others, I think the better it's all going to work out. So just wanted to underscore that point, because it's a really good one, Alice.
I agree with it. And it's also why we always say, bring your team, bring your subject matter experts, be willing to tap into your operational units, because workflows matter. The workflows are what drive the business requirements on how we need to build the software stacks to really enable the abrasion and friction to be removed in the process. And as we get into this really innovative model of transparency and cost and your financial liability, it's just going to become more complicated, because we've got third-party apps, we've got different levels of consumer expectations and capabilities. So it's it's an exciting time. And I know for myself and my family, it's really nice to know the ballpark of what we're going to owe out of pocket. Really helps.
Yeah. And we've even talked about like how this process can actually help with coordination. So like as you're putting an estimate together with others, you realize, oh, this person is out of network for this patient, or oh, we forgot to, you know, check the box on that credentialing or something that's contract related. And it sort of like helps kind of fix and preempt some of those challenges before it even gets to the patient, sort of helping fix some of the challenges that our system has had within healthcare prior to the patient having to experience that burden as well. So it's sort of a burden reduction all around the goal. I know I sound like Pollyanna right now, but that conversation has legit came up on community calls before about how this could really improve things, and as a real world example. So.
Yeah, and I think it's really important to call out that the use case calls are public and open to anybody who wants to come join them. You do not have to be a member of HL7 or a member of the Da Vinci Project. We welcome everyone. They are the conference calls are open, and I know that Leslie has been putting the links to the call details, as well as we've included how to find out about them in the slides that we'll post tomorrow. So please know, you do not need to be a fire expert. You do not need to be a PCT process expert. You just need to bring knowledge and experience and a willingness to roll up your sleeves and participate in the village discussions. So are there any other comments before I kind of went on a sidebar there without y'all? Anyone else want to make comments about the development of their solutions or their level of work and how it's been benefited? Good.
Yeah, I'll take a stab at this, Alex. So when we first started this work 2 years ago, we estimated that if we were to have a unit, it would be 400 to 500 people, which I think Alice said earlier was next to impossible to hire that many people. So we really are leaning on our technology partners, and there's a lot of people out there that are willing to come to the table and be that mediator. So lots of work to do in the technology space in addition to kind of the use case that we need it for.
That's a really great call out. Yes, technology can really help us, but we've got to make sure we design it well for the automation aspects. All right, so let's move on to the next question. The value proposition of engaging in testing and as a call to action of participation. So from your own value proposition perspective, to some degree, you've already talked a little bit about this, but would really love to hear you talking about other examples of why it's important to get involved in the testing effort, not just the requirements development effort, but the testing and your ability to participate. Who'd like to kick us off?
I feel like I keep speaking up, but we really do, as an organization, try to make sure that we participate in as many of the Connect-a-thon testing opportunities as we can. Again, just because of the fact that it gives your internal IT folks the opportunity to get into the sandbox and play and really learn and sharpen their skills, as well as there's also a value for your business folks to attend those, because some conversations that arise in the breakout groups when you're doing these things help you to start thinking about things a little bit differently. Questions get posed that you can take back to your team that might change a strategic direction that you had been contemplating, and you might want to introduce a new idea or concept. So there's kind of value kind of across the board for the different roles that people in the organization play to participate in the testing and the Connect-a-thons.
Great feedback. Others who'd like to weigh in on that?
Yeah, I'll just add one other. I mean, I think it's very different to say everything looks good on paper. At a conceptual level, this will all work together. But then to actually start throwing data back and forth and seeing how it's working, even in a proof of concept phase, is extremely valuable. Putting it forward even further than that and real world data and real world scenarios will really help refine and hone how effective this can be. So definitely, I think participating and being active, and even if being in a connectathon and not even having something to bring and test against, but hearing the conversations and seeing, you do pick up and learn a lot. So great for your technical folks as well as the business operations folks.
Yeah, I think there's always some lessons to be learned from the trial and error of scanning code, whether it's from a workflow automation and modification perspective, or it's from a response time and systems overhead capabilities. I know I've had my own experience with projects where we thought we were good to go. We did a stress test and we had to build it all from scratch. So, I am getting a little bit of background noise, so I don't know if that's just me. Hopefully everyone can still hear us okay, because I've got a juicy next question to ask you, and I am going to run the table, and I'm on this one. What is keeping you up all night around PCT? What are the concerns and worries that you have? And I will take any first volunteers.
This is Tina, and I'll jump in. As I think about the price transparency work and getting the data in motion toward the payers, I think about recognizing all of the partners that might be in the picture and figuring out how to get the initial estimate offering, if you will, to a platform where everyone can begin contributing and create that package to the payer. So finding your partners, first off. And then I think as we think about things being in that platform, realizing when we think it's complete enough, given some of the timeframes that we've seen, when do you think it's complete enough to do the pass through to the payer? And, you know, as the payers get things, I think I recognize that many of those platforms are anticipating a very claim-like experience. And an estimate is so not like a claim as to be completely a 360 turnaround there, but hoping that there's enough information there that the payers can run it through their system and then provide that benefit, certainly for the patients. I think there's so many pieces of that puzzle, you know, even upstream, finding out, is your data discrete enough to even put an estimate into the pipeline? There's just many pieces, and I think healthcare is such a complex part of our world that figuring out how to thread the needle, given all those juggernauts that you're jumping through, spend a lot of time in my subconscious thinking about how to get that needle threaded.
And Alex, this is Zach. Just to build off what Tina's already said, you know, we really are looking at estimate accuracy. Our patient experience is key here. And so keeping me up at night is how to get that deductible accuracy so that our patients get the correct estimate up front without a refund on the back end.
Yeah, that moment in time reality and the incoming claims, and not just the incoming claims, but also you have to think about all those dynamics with appeals that can be processing in the back cycle as well, or the claims processing cycle that can really impact really that moment in time estimate, which in 2 seconds from now can be no longer valid. And how do we not create that frustration with the patients related to the estimate being off to some degree, even if there are disclaimers galore associated with it. Yeah. Really good feedback there, Tina and Zach. From the provider's perspective, appreciate that and all of Providence's leadership in this use case. So next, who'd like to talk about what's keeping them up at night worrying about PCT rollouts?
I'm sorry, Alex.
No, go ahead, Carmen.
I love that everybody's being kept up at night. I'm not alone.
So many things to keep me up at night. So I think for CMS, what really keeps us up at night is just making sure that we get this right the first time. So we've recently partnered with the U.S. Digital Health Service at CMS to conduct user research and with providers, payers, and other stakeholders like EHR vendors and clearinghouses with regard to GFEs and AOBs. And I think one payer perfectly articulated what's really, you know, at top of mind, and that they said that if at first rollout isn't accurate, at least a decent amount of time, going back to the accuracy comment, we're going to lose those consumers, and it's going to take us 50 years to get them back. And I'd say that that's pretty accurate, and that's really one of our primary concerns. But another issue that keeps me personally up at night also ties back to your comments earlier about the standards and the need for standards in this space. And so, CMS recognizes the incredible amount of work that goes into community-driven standards and the value that these open standards bring to enhancing interoperability. We also recognize the importance of testing these standards just to ensure that they function as intended and that they benefit all of the stakeholders as much as possible and that they're scalable. And we also received comments in response to the RFI regarding testing standards and the importance of the standards. Some of the comments actually mentioned that it's less important about which standard that we go with than it is that those standards are tested in real world settings. And so we're really in a kind of a difficult position now where we really want to see more testing, but we unfortunately lack the funding, and many of you may know the status of the government at the moment. And so, we invite everybody on the call, including panelists and anybody else that is listening into the call, to really engage in the standards development efforts that Vanessa is leading, and engage in additional testing efforts, whether it's at a connectathon or perhaps a pilot. So we currently lack funding to fund a pilot, but invite anybody else who may be interested in facilitating that pilot to please allow us to simply act as observers or to help provide clarity where needed, but to continue to engage, and really we want to keep our thumb on the pulse, I think, of testing for this particular IG as much as possible.
I think Alex is muted, but I'll jump in here real quickly. I will say that interestingly enough, we're right there with Providence, because for us as a payer, if the convening provider can't bring to us something that is a consolidated set of information that needs an estimate, what the payer's going, regardless of how great we figure out how to pull that in, bounce it against all our different systems and send back something that's accurate, it's only going to be accurate to the extent of the question being asked, right? What service or procedure or what have you is being done? Is it bundled? Is it all that stuff? Is that the individual par, non-par, contracted in network or out of net? I mean, there's so many different variables to that have an impact on how right, Carmen mentioned it's really important we get this right initially so that we don't lose confidence. That's going to be the challenge. And I know that's what we're focusing on in this second part. It's one of the reasons we're focusing on it is because all of us are like, it isn't going to work unless we figure out, and this is actually asking, I often say when I have the opportunity to talk that CMS is actually disrupting the entire healthcare business model with these different mandates, the 9915, the 9115, the 0057, not to mention what Congress has come and done with the Consolidated Appropriations Act and the No Surprises Act, or Surprise Billing Act. So these are things that as an industry, we're all having to rethink. Providers are having to rethink, how do we interact with the providers we refer to or interact with? And EMRs are having to rethink, how do we help the providers who use our EMR system to interact with the providers that they interact with that don't use our EMRs? Like everybody is being asked to figure out a new business model with all of these cost transparency and interoperability mandate rules. So that's definitely something I think we're going to probably wind up getting it. We need to shoot for getting it right, but we need to kind of define what right is, and that it is going to be something that we're going to have to continuously improve on, because that's what technology does, is continuously improve. So I think it's going to be interesting for us to find out what our definition of right out the gate is going to be. And I see Carmen kind of nodding her head there too. Jacob, I don't know what you have to add from the vendor EMR perspective, but we're real concerned about that too.
Yeah, I think, to address the larger question of what's kind of concerns that we have, it's the general timing of all this. Like, this is the collaboration that the No Surprises Act is going to give between providers and payers and patients is to a level that we haven't done before. So it's all new to everybody. And I think if we try to go too far too fast, we can end up in a place where people end up having to cut corners and get something out there. And that could be at the expense of the patient experience. And a number of people reinforce that you lose the trust of the patient there. They get a sour experience from it. You've kind of lost that already. And so having a false start would not be great here. And it's going to take time for the industry as a whole to make this shift and figure out the way to work together and collaborate to a degree that we just haven't seen before. And some of that is, like Alice mentioned, the upstream inputs and parts of it. Some of it is the sending the information downstream. The reality of discussing the cost of care with a patient is both providers and payers are having those conversations. And we think it's really important that all of the parties are on the same page and sharing the same information and messaging so that the patient is not put in the middle and being left in the lurch on who should I trust, what's right, what's not, what's actually going to happen for my situation.
Yeah, there's also probably a patient education aspect in all of this to manage their understanding of what are the timing dynamics, because we will never remove those because we can never sequence everything, or else we would never get it done. But I want to keep going round robin. Vanessa, do you have anything to add in so far? You've been patiently.
Thanks, Alex. That was so fantastic. I was making a list of all the things that keep me up at night, and I think you all collectively touched most of them from what we've heard in the community. Really, really terrific. So I can add that two things, one more specific. So Jacob, you mentioned timing, and I think timing of the rollout to get this right and defining what right is, to Alice's point, is really dead on. And also timing within the patient journey for the level of information, which we talk a lot about, right? You may have less specific information early on in the patient journey, whereas if it's 3 days before the service, you'll know a lot more and be able to ideally have more inputs to be able to give a more accurate export, which a lot of people had a lot of staying up at night over for a long time. I think holistically, the goal here, right, is to prevent surprise billing for patients and to enable them to make more informed decisions about their care, along with other aspects, quality, location, comfort with their provider, language, right? That there's a lot of factors in here. And so I think it's important that we remind everyone that cost transparency is one piece. I think it's a very important piece that we've got some work to do on in the industry, and that's what we've been doing here in Da Vinci for the last 3 years. And getting it right for me would be along those lines, right? How do we get patients enough information? Maybe it's not going to be perfect right away, but so that they can make a more informed decision, or they can at least know, hey, let me ask some questions about this before I go into it, rather than us seeing month after month all of those bankruptcy stories about patients that got that surprise bill and got into a lot of challenges.
So much of what we do here is within the Da Vinci project is about transforming those patient outcomes, and we're focused mostly on value-based care information exchanges, but that really does also translate into a different form of outcome for the patient. We think about the health outcome, and finances is definitely a part of that conversation, and the whole person care that we really want to see take hold in our country and all of our lives.
And the stress that goes into financial strain. And I won't put my other hat on right now, but social determinants.
Yeah, you can acknowledge that you are also the program manager for the project. It's a pretty important project for social determinants of health and social drivers that do impact that quality of life outcome and the equity issue.
Thank you, Alex.
All right, so opening it up for other final comments, in case people want to chime in on what's keeping them up at night or other comments that our panelists have made. I know.
All right, one more keep me up at night is ensuring that in all this great work that we're capturing all of the voices of the community, right? There's always pockets of, rural providers that are one doc practices, or, others that aren't necessarily represented through people that are able to come week after week and contribute to standards. I am kept up at night by hoping that we are ensuring we're harnessing their voices in our standard development. So I'll add that.
And I'll add one more thing too, something that we've kind of chatted about amongst ourselves, is also once the cost data gets shared per procedure with providers, this is going to be different data than they've ever had before, and what kind of impact is that going to have on how they look at things, they operate, etc. I think that that's going to, especially if they're engaged in any kind of value-based reimbursement contracts, etc. So I think that there's some very interesting, what does the future hold for us? And it's going to be exceedingly important for us to do a lot of testing to make sure we're doing this responsibly, and that we're being open and transparent with each other through this process on what the impacts are operationally, technically, etc. throughout the whole process, because there's a lot of opportunity for us to all get better, but if we don't do it collaboratively, we won't wind up with that.
Really well said. It has to be good faith in the village to get to the right outcomes for GFEs and AEOBs to really advance PCTs. And I'm going to stop my acronym game now and thank all of you for participating in today's Community Roundtable. We welcome you back October 25th for the deep dive into the overall use case update from the Da Vinci project. And we hope that you have a terrific balance of your day. Thanks for joining us. Bye-bye.